Welcome to Pause for the Truth, where you can sit back, relax, and hear an honest dialogue about health, wealth, legal, and social issues. The hosts are Dr. Rogers Kane, family practice physician, and Jocelyn Turner, health education consultant, with co hosts from the Northeast Florida Medical Society and its foundation. Stay tuned for the truth about matters affecting you and your family. We're here to tell you what's really going on and why.
Yeah, I got it.
Good evening and welcome to Pause for the Truth. I am Jocelyn Turner, your co-host, and my co-host, Dr. Rogers Kane, just sent a text panicking saying his internet went out. I don't know. This might be a time for our behind the scenes guy Tyrone and I to make a have a little fun about Dr. Kane and his internet went out. It's like that sounds like user issue. Tyrone, what do you think? What's your bet? What's the odds?
Well, what I will say is with Dr. Kane, we can always blame him for user error for something.
How you doing this evening, Tyrone?
so
Yeah.
uh,
So
we're going to,
Tyrone, I'm gonna excuse you for a moment to help Dr. Kane and our other guest, Dr. Jones, get in. And I'll just start chatting with our guest, my friend. She used to call me her mentor. I don't know if she still does. That's because she's been doing more fabulous things than I have been doing. But she is none other than Monique Denise. How are you doing this evening, Monique?
I'm good.
You're good. I like how you sang that. And people are going to learn more about you tonight. Like you saying that answer, I'm good. Like you're giving us that little lead in, but we'll talk more about that this evening. And my co-host, Dr. Rogers Kane, has joined us, although he's muted. How are you doing this evening, Dr. Kane?
I'm doing great. I'm trying to make the arrangement to get our other guest home. So
All righty, dighty. Well, tonight's subject is one that's very important. If you didn't know, to our viewers, October is Breast Cancer Awareness Month, and we put on our pink shirts and we go and participate in walks and do what we think is our part. However, tonight we have someone with Monique who can share her personal journey with breast cancer. And I can tell you, if you've not met Monique Denise, then you are missing out because this young lady you would not believe her story, which she's going to talk about tonight. Let me tell you a few interesting facts, and people probably wonder why we decided to focus on breast cancer in African American women. Let me give you some interesting statistics to let you know why. With the exception of white females, Black females are more likely to receive a breast cancer diagnosis than those belonging to other racial or ethnic groups. In the United States, the rate of new cases per 100,000 people is 137.6 for non Hispanic white females, 129.6 for non Hispanic Black females, 111.3 for non Hispanic American Indian or Alaskan Native females, 106.9 for non Hispanic Asian or Pacific Island females, 99.9 for Hispanic female. The relatively high prevalence of breast cancer among Black women is likely related to a combination of biological and social factors. And so I was reading the article and I did a screenshot just of those facts. And let me go on to another story that I read, because Monique, when we get ready to talk about a particular feature, a particular topic, we like to do our homework, obviously, with Dr. Kane being a primary care physician and I'm just a little health educator. I still have to do my homework. And many of you have heard of Terry Crews. Terry is famous for his jumping pecs. Is it pecs, Dr. Kane? His jumping pecs, right?
yeah.
And so, but Terry Crews' wife, Rebecca Crews, received a stage 1 breast cancer diagnosis in 2020 following a mammogram and ultrasound. She is cancer-free. In this article, it said she was cancer-free after a double mastectomy. Cruz often shared uplifting messages for her followers. In a post, she reminded her followers that we can gain strength, courage, and confidence from every life experience. A cancer battle, or any struggle for that matter, can lead to a whole host of complex emotions, and it's okay to allow yourself to feel the negative ones too. Holding on to hope in the face of adversity can be a real powerful way to get through the toughest of times. Monique, I'm going to start with you as we wait for Dr. Jones. Tell us about your, and I call it a cancer journey, but no disrespect for you, but I remember when you got your first cancer diagnosis. Tell us about that day.
Ooh, I was actually working at the health department, so rightfully so, my office was right down from yours, so everybody knew. But that day was very challenging. I had a lot going on in my life, which we all do, in most cases. And so it was the last thing that I was thinking about. I was diagnosed when I was 35. So, being a healthcare educator at the time, you think I'm too young for it. Had my baby. She was 2 years old at the time. And I actually ended up going to get checked because I would have a pain in my breast, in my left breast, and the pain would just it was a sharp pain that would just come and then it would go away. And then I wouldn't experience it for a few days. I was breastfeeding my last child at that time, and my left breast stopped producing milk. And I went to the doctor, told them about my concern, and they told me it was possible that my milk ducts were swollen. Working in the health field, being a health educator, I was like, no, ma'am, that's not it. I have lactation consultants that I can go to. But she kept telling me that's all it is. You just have to do this. And, many of us put a lot of confidence in who we do see. So I just walked away and I went with it. Um, that was probably a year later. I was still having this pain. So I ended up going again because I was pushed and persuaded by a friend of mine that I really needed to go get attention to this because as a woman, a mother, a wife, most of the time we put most of our concentration and focus on our kids, our husband, and those things. So I ended up going and I went to a different doctor. So when I went to this doctor, she was doing my mammogram and she immediately noticed that something wasn't right. She sent me right away to get my mammogram, and then they sent me right away to get a biopsy, and then right away to get that ultrasound because I have very dense breasts, which is something that women definitely need to know what type of breast you have. Um, but then I went and did that. Probably 2, 3 days later, I got the call while I was at work to let me know, and it was from my primary doctor that I had breast cancer. And then from there, it was just
You got
chaotic.
a call at work, Monique?
I got my call at work. Everybody was off the floor. Thank God, because if everybody was on the floor, everybody would have heard me scream.
So they told you that over the phone?
So my primary care doctor did not want to tell me over the phone, but she wanted to tell me because she was like, I'm surprised you have not been informed already. So she was concerned because she knew I had already been having issues. And from what she felt when she did the exam, she was very concerned about it. And she had been checking on me ever since I saw her last. So yes.
That's the same, and then we need to introduce Dr. Jones right quick. Is that the same primary doctor you went to when you first was having the issue or separate?
This is a different doctor. I went to a different doctor.
Gotcha. Okay. Johnson, we want to go ahead and introduce Dr. Jones. So people have already know him anyway, but still.
Yeah, welcome, Dr. Kenneth W. Jones. How are you doing this evening, Dr. Jones?
Good evening. I'm well. I'm finally in.
Yeah, sorry you were having some technology issues, but our behind the scenes guy, he helped you come on in.
That's right. He got me right in. Yes.
Yeah. He's much better at surgery than he is at technology.
Dr. Jones, Monique Denise is as you heard her story, she was diagnosed um, with her first breast cancer diagnosis at the age of 35. One thing she said, and I'd like for you to explain it to our guests, she said that she had dense breasts. What exactly does that mean? And what's the difference between dense and not dense?
Well, many ladies have different forms of breast tissue, and the younger ladies have usually very dense breasts. As you age, your breast becomes less dense, it includes more fat, and that's something we see. That is the reason why, as physicians, ladies that have dense breasts with suspicious masses, many times we would get an MRI of that breast because it can give us more information. It's more sensitive. So a dense breast in of itself, but what I heard during her presentation is the fact that she was breastfeeding. She had just had a baby. Those are very difficult breasts to evaluate. Also, even sometimes when you get a biopsy, it would sometimes take 2 and 3 pathologists to review it because the breast during that time of lactation is a very active, all the tissues are active. So they take some time when they make that diagnosis in a pregnant lady. More than likely, that person does have breast cancer. It's not a light diagnosis. Many people look at that side when ladies are lactating because it makes the reading a little bit more difficult.
So you said sometimes an MRI is needed. Who makes that determination? Because as you know, and I've shared, I think I shared before my journey with going through getting a mammogram, a routine mammogram that ends up being, oh, we need you to come back and get another one, and yada yada yada. So who makes that decision that it's time for MRI? Can I request?
Well, I think that goes back to the most important piece is breast cancer screening, because that's the important component in survival. And if someone is screened, and what we mean by screening is that 40 to 49 every year, after 49, you must have it. And for someone with a history of breast cancer, a family history, normally we would get a mammogram 10 years prior to the time that person's immediate family member developed breast cancer. So if your mom developed breast cancer at 40, her daughters will get a mammogram starting at 30. Mm-hmm. That is the usual standard that many people adopt.
And so that's the protocol. You saying get the, let me make sure I got it right. The protocol somewhat, algorithm somewhat, is that if their parent had breast cancer at whatever age, you try to go for 10 years earlier for the offspring to go on ahead and do okay.
Yes.
Got it.
And usually 10 years prior to the age that the first degree relative developed breast cancer. And of course, things do change. If that first degree relative also is BRCA positive, that carry the breast cancer gene, BRCA1 or BRCA2, that is something that we know African American women, though being diagnosed at an earlier age, and it averages about 60 for African American females, they still have a higher incidence of triple negative breast cancer. What does that mean? They're estrogen receptor negative, they're progesterone receptor negative, and they're HER2 negative. That carries a worse prognosis. So the most important is early screening. By that is, don't miss your mammograms, because we have good data. If you're identified with a breast cancer at stage 0, 100% of those ladies are usually alive at 5 years. If you go to stage 4 disease, about 18% of those ladies are alive in 5 years.
Mm.
So it's important that, one, we do not overlook any change in your breast. The ladies have to be the experts as to what their breast feels like, what it should feel like. And if they have a spouse, the spouse should understand that too. Because other than a mammogram, and I think we should take it to the next level, we all do 3D mammograms today, not the old-fashioned standard 2D mammograms. So when you read a mammogram report, make sure they've done a tomosynthesis, which is a 3D mammogram. That's what's considered standard today.
Dr. Jones, I read that breast cancer is one of the most common forms of cancer among females in the United States, second only to skin cancer. 1 in 8 females in the United States would develop breast cancer, but certain groups are more at risk.
Yes.
For instance, doctors most commonly diagnose breast cancer in non-Hispanic, white, and Black American individuals. Why is it that African-American women seem to die more from breast cancer than other groups of people? Or is that an accurate statement?
Well, I would say that it is true, okay, that African-American women, when they develop breast cancer, we're usually younger. And the fact that we are triple negative, which is the one that's difficult to treat. It's not like you could use hormone therapy to help suppress it after treatment. It's all chemotherapy when you're triple negative. So we have a higher incidence of triple negative breast cancers in the African American community. Why that is so? That's what the researchers have to start looking at. What it is about the genetics of African American women, what it is about the chemotherapy that's available. Is that the best chemotherapy for the African American female? Do we know that? We don't. I mean, 1 in 5 African American females, when they develop breast cancer, have triple negative breast cancer. And if you develop triple negative breast cancer, that's why the data seems to show that that is the reason why African American women have the highest death rate from breast cancer.
So am I more at risk? For example, my mom's sister had breast cancer. Now, truth be told, she was in her 80s when she was diagnosed. Dr. Jones, I have to, not that this matters with anything, but you were her doctor actually, and she did okay with it. She died about at age 89 from something else. But when are you at greater risk depending upon who your relative is? You know, is it a mother, grandmother, aunt, more so than a cousin, for example, or does it matter as far as
first degree relatives, your mom, your grandmother, your sister? Those are the highest risk. And as you know, if you look at the overall data, okay, African American women in the United States have a higher chance of developing breast cancer before the age of 40 than Caucasian females. I mean, that's just the data that we have. And, you know, if you were to break it down within the American diaspora, you would see like Native indigenous people, Alaskan indigenous people, they have the lowest rates of developing breast cancer. And then you go up the other groups, Asian Pacific Islanders, you know, they have less than African American females. And the data is Asian Pacific Islanders have the lowest death rate from breast cancer, while indigenous Americans have the lowest rate of developing breast cancer in the first place. Now, that could be all genetics. Have we looked at it really? I mean, from the eyes of an African American researcher, it's time that we look back to doing genetic research as to why, what it is about the African American female breast tissue and her, and don't forget, his genetic makeup puts them at an increased risk of developing breast cancer. And we must mention here the fact that men can get breast cancer too. So if the male's mother and say grandmother had breast cancer, that man is at an increased risk of developing breast cancer also.
Mhm.
I try to remind our men that, hey, look, and it's not arbitrary. I read it somewhere. Not one out of every 100 breast cancer cases may be a male. And so while that is a much smaller number than the women, it's still, you don't want to be that 1 out of 100. And not
Exactly.
the other thing that I would like to throw into the bucket is that not only do we need to look at the genetics, but we also need to look at the social economic situation, the physician-patient relationship. And I know sometimes I'm being, that may be a little bit more specific as to what kind of physician you have. Do they understand your culture? Do they understand you? Would they talk to you? It ain't just the genetics, even though genetics playing a huge role, and that's what research, when we try to do these research on things, it's not just the genetic. It is a lot of other factors that could be playing a role as to why we're tending to have more of us die.
Well, Dr. Kane, for instance, there's a higher incidence of breast cancers in obese women.
Yeah.
There are higher incidence of breast cancers in people that don't eat adequate amount of fruits and green vegetables and just legumes, the different things. Now, that goes to a whole socioeconomic issue where you go into some communities and there's no place that you can buy fresh fruit or green vegetables. All they sell is cured meats or a lot of cheap red meat that is not healthy for your body. So it's a bigger picture when we look within our community. There's the medical piece and there's a socioeconomic piece. We have not gone into communities and said, what's the incidence of breast cancer in this population of people, say African American females who live in zip codes 08, 09, 07, for instance.
It's just
Who has that data?
Yeah.
And then if we do find that, can we get tissue from those ladies? Can we do actual research to understand what are you eating? Or the environment you live in? Are you living on a place that was previously, they dumped ash from the coal company? I don't know, but I'm just saying we need to still look at all of that. And then, of course, having a doctor that understands you and understands where you're from and understand the conversation that we have to have with our patients regarding getting screening. Because remember, the earlier you develop breast cancer, the earlier it's diagnosed, the better you will do.
So I want to transition back to, thank you, Dr. Jones, to Monique. Monique, I've known you for a long time when you were knee high to a tadpole. And I can recall you were in pretty good health when you initially got your cancer diagnosis. Did you have a family history of breast cancer before your diagnosis?
It wasn't a direct correlation. I did do the genetics testing, and we learned, me, my mom, we all learned a lot about our family. So it was down the line, but nothing that directly correlated or connected towards me. So no, there was not necessarily a family history like that.
And where are you now with your cancer diagnosis?
So
if you don't mind me asking.
Yeah, no, that's fine. I have stage 4. It was stable. Right now we're in a situation where it is still spreading. It has started spreading again. So it's in my liver, my lungs, it's in my bones. I have parts of my spine that are fractured, parts of my rib that are fractured because it weakened my bones and caused the fractures before we found out. it's in my brain. And so yesterday I had to have radiation on my brain because the spot in my brain had increased, doubled in size since my last MRI, which was 2 months ago. So where I am right now, we're trying different medications. I think since April, I've probably tried, this is my third medication. I'm in the process of possibly going out to Texas to go to MD Anderson in Houston just to see what other options I have, if there are clinical trials, just to get, not just stay right here and get stuck where I am and just think these are all my options. We're trying, I've gone to the islands. I've heard them give me, the herbs and the spices. I hear everybody telling me to cut out meat. I'm just trying all kind of stuff right now at this point. But like you said, I was very healthy. And they always say, if you look at me on paper, I'm a perfectly healthy, young Black female, which, is just kind of mind baffling to me. That's why I went in such a shocking place when I found out that I had it. But again, I understand that has nothing to do with it either.
Listening to her story, if you develop breast cancer in the perigestational period, meaning your breast cancer tends to spread more by the time it's diagnosed. Because most people, meaning that when you're pregnant, breastfeeding in that period, because most people feel, well, your breast is swollen because you're breastfeeding. Well, we can expect that. Meanwhile, the cancer is growing very rapidly during that time because that's a time when the breast is reforming very rapidly.
Right.
And then most patients that I've found over the 40 years I've been doing this is that if I diagnose a young lady, and I have some right now who, I have patients who have 3-month-olds, 1-month-olds, 6-month-olds, and most of them are stage 3 or stage 4. They have metastatic disease already by the time the diagnosis is made. It's because we don't think that a lady who, people say, well, your breast is going to look and feel a little different during your breastfeeding, so don't worry about it. Let's look at it again in 6 months after you stop breastfeeding. Meanwhile, all that time, the tumor is growing and metastasizing.
Yeah.
And that happens a lot. And I think it becomes a part of training our residents and our physicians to think that, yes, you can get breast cancer during your pregnancy. It can happen.
The elephant in the room, to be honest with you, I'm always looking at different angles, but one of the elephants in the room is, again, it goes back to who your physician is and their philosophy in terms of taking care of patients. I think before Ken got online, I mentioned to you guys that I had the luxury of, he says 40 years. Yeah, we're close. I'm not quite the 40-year guy, but I'm close. I've had the luxury of being able to call up on him and say, I'm not sure. Can you help me out with this? You make sure that you do everything you can for your patient to get to find out as soon as you can what is going on. And of course, you want to make sure you have a knowledgeable, not only a knowledgeable, but a caring physician. So he makes me look good all the time because he is caring and he knows what he's doing. And so I would like to encourage any of the ladies out there to make sure that I'm not saying second guess your physicians, but be wary of some physicians just don't either know as much or care as much, or a combination of both.
Well, just going back to what you said earlier, 85% of the ladies who develop new breast cancer have no family history of breast cancer.
Yep.
Think about that. 85%. So you may say, oh, we don't have a mother or a father having, because we've seen people, you get a mammogram, and I'm going through this with a friend right now, got a mammogram. They said, oh, come back in 6 months. She sent me the mammogram. I read the mammogram. I said, you know what? If this was my sister or my wife, I'm getting an MRI. I don't trust this. So we had to fight, of course, to get the MRI because the doctor there is saying that the radiologist in that other state didn't think she needs, they don't think it's much. You know,
nobody that has no contact with the patient. Someone that has no contact with the patient.
We fought for that. They went ahead and did the core biopsy, and then they called me and told me she has DCIS, which is the earliest stage of breast cancer, which is where you want to diagnose it.
Right.
At stage 0. So you can do a lumpectomy and follow that with radiation. She's ERPR positive, so she'll, go on a medicine that's going to give her hot flashes, unfortunately, but you'll be alive to do it. But here's a classic example. This sister goes there, gets her mammogram. They say, oh, it looks, but come back in 6 months. And then she called me after she went back in 6 months, and they told her to come back in another 6 months. And then that's when I said, send it to me. Let me look at it. And then I said, if it's my mother or my sister or my wife, I want an MRI.
Yes.
And the MRI is more sensitive. And it gives you more, it's more, the specificity, the sensitivity is significantly better than a regular mammogram.
Yeah.
And nobody should be getting, and going back to early detection, you must get tomosynthesis, the 3D. I mean, if you go to those places and the bus comes around, very few of those buses have a 3D mammogram in it.
Right.
Okay, so get your doctor to order a mammogram, and that mammogram has to be tomosynthesis. And the difference is that tomosynthesis, it gives you an arc, a 30-degree arc as you look at the breast. Totally different mammogram than the old mammograms people are accustomed to seeing. It's more sensitive, and you get better. And the cuts that they do are like 1 millimeter. So you're getting all these, they're building an entire image at 1 millimeter cuts. So at least it's better than a routine mammogram, but the MRI will be the most sensitive of them all. I think the sensitivity of an MRI is like 74% on the new ones, and the breast is about 40. But a specificity is higher in the mammogram than in the MRI. But the MRI picks up things that you have not seen on the mammogram. And that's the difference with an MRI. And of course, most insurance companies don't want to pay for an MRI unless you have a diagnosis of breast cancer.
But then you don't need it.
We've got to constantly fight and be advocates for our patients.
Remember, Ken, and we won't call patients' name, but we have a mutual patients. I remember doing a mammogram on them in January, and they came in and saw me in July, and it was about something altogether different, a cold or something, but they happened to mention that they had a little bit of discomfort up under that. I went back and looked at the mammogram, perfectly fine. But I went on ahead and repeated the mammogram, and I think that time we did do a tomosynthesis just to highlight, and when that mammogram came back and it showed breast cancer, I literally was cursing the radiologist out, because I thought they just did not pick it up and missed it. When in fact, when we reviewed it, it was not there in January. And it was showed you how aggressive, one, the breast cancer might have been, but two, also the mechanism by which, and I'll tell this story just to highlight what you're saying. Two, about the mechanism by which which mammogram we obtain, that's being more sensitive than, like you say, the 2D or the regular mammogram.
Yes, always order a 3D tomosynthesis. Okay. And when they compared the 2D versus full field, which is the old mechanism, the 2D, the 3D is the most sensitive. So that's the mammogram we get today. If people are listening, if you're getting your mammogram, get a 3D tomosynthesis mammogram. And you will know exactly that you're getting one, because that machine moves in a 30-degree arc.
Right.
If you're standing there with the old-fashioned one where they're just taking a picture, it's not a 3D. So please request that your primary doctor or whoever your doctor is order a tomosynthesis. That will give you a better mammogram. And if they're concerned and they keep bringing you back every 6 months, stop. Get an MRI and a core biopsy. Don't play around with that.
Yeah, find a second opinion for as I'm concerned.
And who should make that? Who should make that call? Do you go back to your primary care doctor?
Yes, your primary care doctor could. Or what happens many times is that I would get a referral from a primary care doctor, and I would review it, and I said, "This is the next step." Then it's up to me to fight for that MRI. And I would many times talk to people on the phone. And my only thing, well, why do you want it? I said, because in my clinical opinion, I think this is what's going on. Well, it doesn't fit our algorithm. I said, I tell you what, give me your name. Give me, and so if we find cancer, I'll have the person's lawyer call you directly. And all of a sudden, you know, they hang up the phone or they do something crazy, and then next thing you know, you see the referral come through.
Oh, your mammogram. That's right.
Wow.
Take the responsibility. If you're treating the patient from afar with an algorithm and you've never touched the patient, seen the patient, I have a problem with that kind of medicine. That's not the way I was trained.
And I don't give up on it just because, oh, the radiologist said you don't need it. It's like, hell no. We're gonna do a workaround.
Yeah.
A lot of times I do get Ken involved, and I tell that patient, take your mammogram with you for him to look at it as well. And I think we'll just tag team and beat up on this insurance company. You know, the radiologist is nobody other than a person that's kind of trying to enforce the algorithm that they have come up with. It's like, let's go after the insurance company and let them know if you don't do it, here's the potential of what may happen if we're correct.
Now, I have a question for Monique. What are you triple negative?
You muted, Monique.
I am. Yeah, I'm not. I'm not triple negative.
So you're still getting an anti-estrogen?
Or
they stopped you?
Yeah, they stopped all that because I'm in active chemo. But I was on, tamoxifen.
Mm-hmm.
So I had the heat flashes and all of that. But yeah, I'm not doing any of that. It's probably mixed into what I'm like right now. I'm on Xeloda. That's the chemo that I'm on now that doesn't appear to be working. So from what I was told, the next steps could potentially be putting me back on the IV chemo, which I don't want to do because that's what made me sick. And I'm just praying to God that I don't have to do that, but we'll see.
So Monique, tell our audience what you do. You stay so upbeat. What has helped you to deal with this, obviously, other than your spiritual faith and your family?
Well, unfortunately, I had to stop working in the health field because of the pain that I'm in most of the times. And then I get these migraine headaches. So what I do, I have a passion for singing. I've always loved singing. So now I've just put more of my free time into singing and performing. And my doctors just keep pushing me to continue to do it because it's my outlet to just keep my mind off of the downside and focus on the positive side. So a lot of times I sing and I push my initiative, which is educating people about breast cancer. I make people aware of what I have going on. And my motto is now or never, living life to the fullest, and just encouraging people that just because I have stage 4 cancer or you have some disease or condition, it doesn't mean that you have to stop living. This actually should be more of a reason that you push to live. That's why my album that I'm getting ready to release is going to be dedicated to breast cancer, because I feel like it's just part of my purpose.
I see that baby grand in the background, so I hope.
Yeah, I
hope you're making those chords talk.
So should I expect for you to belt out a couple of chords right now so that people will know? No, I'm just teasing. I won't put you on the spot like that. So Monique, you mentioned that the cancer is spread to your lungs, so it's not causing difficulty for you to sing?
So that's okay. Again, all of these things are just crazy because I have breathing issues now. They sent me to do a asthma test, but my lungs weren't strong enough to complete the test. So they can't determine if I have asthma or not. I don't know if y'all have heard, but I've been wheezing the whole time. Like I will get up and walk from my couch to my stairs, which is literally like 10 steps from where I am, and I'll be completely out of breath. But they cannot figure out what. They've done the scans, they don't see anything, but I'm like, I need somebody to tell me something because not knowing and we can't figure it out and just giving me an inhaler doesn't help, but it does affect my breathing. I mean, my performing and my singing because, whereas I could do a whole 3-hour show and I'm good, now I'm out of breath. I'm tired, can't hold my notes as much. I mean, not to mention the chemo affects my memory. So now I do have my tablet to just remember my words, but I don't let it stop me.
Well, many times chemotherapy will cause pulmonary hypertension, and the pulmonary hypertension could result in significant shortness of breath, especially on exertion when you walk. If you're sitting, it's okay, but the minute you get up to walk, you will have difficulty breathing and oxygenating because of the chemotherapy effect on the lung tissue. And they can evaluate you for pulmonary hypertension. Most times it's not asthma.
Okay.
The other, in addition, when you talk about pulmonary hypertension, we just talk about high blood pressure in the lungs. You may not have to have high blood pressure systemic, the regular high blood pressure people talk about, but you may have it in the lung. The other thing that I wanted to throw out was that some of the chemotherapy can also affect your heart, which in turns affect your ability to ambulate, walk around, shortness of breath, heart failure, that kind of stuff. So there's a big a whole lot of things to consider when we are treating patients like this. Monique, can I ask, how old are you?
Well, I'm 40 now. So I've been dealing with this since 35. So for 5 years.
5 years.
Yeah, that's what I was trying to figure out. Okay.
Yeah. So, and that's crazy that you say, you guys are giving me these options because everybody's trying to tell me I'm out of shape. And I'm like, I'm not out of shape.
No, that's got nothing to do with it.
I need to go to the
not
gym.
out of shape.
Yeah.
Now, what's interesting? If it's early stage pulmonary hypertension, higher doses of Viagra, which is genetic, the same medicine that is Cialis and Viagra is what you take for that.
Right.
Because it increases nitric oxide, and the nitric oxide dilates your pulmonary veins.
Okay.
So there are things that you can do, and maybe you just need to ask them, have you guys checked my pulmonary, to make sure I don't have pulmonary hypertension?
And did they do an echocardiogram, which is like an ultrasound of your heart and stuff like that?
Yep, we did all of that.
Yeah.
We're even talking right now because in the last 2 months, I've lost like 25 pounds just out of nowhere. I've lost 25 pounds. So I'm just trying to figure all of this out. That's why I'm willing.
Well, we're gonna continue to send up additional prayers for you.
Yes.
Yes,
Amen. So how are your children dealing with this? You have beautiful children. So how are they dealing with this, Monique?
So you said their ages, Dr. Kane?
Yes.
Okay, so I have an 18-year-old son who's in college. Then I have a 13-year-old daughter, and then I have a 7-year-old little girl. So honestly, my 18-year-old, he really hasn't showed much emotion like from day one. But as he's got
it's a boy thing.
It is a boy thing. It really is. It really is. But since he's been gone to college, he calls me all the time. He sends me text messages. I love you. How are you? We're going to be okay. You got this. So he's encouraging now. My middle daughter, my 13-year-old, she's very sensitive and emotional, but she's strong. So she doesn't like to hear like she didn't like to hear when it came back. But the baby, she's just, well, Mommy, I know you're sick. She doesn't like me sick. She don't really get everything. But I will say I have some very strong kids because what I realize also is my personality, how I handle everything affects everybody around me. So as long as I stay positive, and when I'm with them, I try to still move around even when I don't feel like it. They stay pretty consistent and they're good. So they don't have to see the bad side of it all the time.
Ken, I would like to ask a quick question. Well, two things. The youngest breast cancer case I ever had to diagnose was 19. I don't know if you've seen anything earlier than that.
Believe it or not, this afternoon I got a call from one of the local hospitals who said they have somebody age 14.
Wow.
That they want me to see.
Yeah.
And I said, "You sure?" I said, "I want to see the slides, of course."
Right.
So I'm getting the slides, even though they give me the age and they gave me a diagnosis. I said, "Please send me the slides with it."
Yeah.
And, they're talking about a 2.1 centimeter mass that's palpable.
Right.
I said, well, let me see the slides. But they were definite that's what it was. And I said, nah, let me see the slides. I'm going to keep hoping.
And you're talking the pathology slide, the biopsy.
Yeah. The biopsy slides. I'll be like Jesse Jackson. Keep hope alive.
Right.
Yeah.
Man,
I've actually heard of 12. Like in this venture and the people that I've met, I met a young girl who was actually 12, and I just mind blowing. I just did not believe it. Did not.
One other quick question, the other side of the question. And this is kind of extraneous type question. The role that maybe estrogen is playing, and I'm not talking about giving a woman estrogen necessarily, but estrogen in our food supply, our water supply. You got any comments on that? Or, I know there's nothing.
Only data we have right now, Rogers, is the fact that we have seen a decrease in breast cancer overall in populations, and they're thinking that's because they're not giving women hormone replacement therapy like they used to
anymore. Right.
Now we shouldn't be putting estrogens and stuff like that in our food sources,
which we were.
But we don't know what some of these food producers are doing. We don't know what these chickens are getting. We know they can't put estrogen in the soil when you're eating green vegetables and lettuce and kale and all that. But the minute you pick up a pork chop or a steak or chicken breast or we don't know.
Remember, you said
now selling free range chickens and all that. But in the old days, to get that chicken nice and fat and plumpy, they gave them all types of stuff.
A lot of estrogen. And the other thing is, and when I say water supply, because a lot of times people get their medications, the first thing they want to do when it's outdated is dump it in the toilet. And when they clean up when they clean up the to filter the water and stuff like that, they don't necessarily take out the contaminants of drugs. They may take out some of the gross stuff in terms of our sewer, but and so it's just a question I just threw out.
Well, can I ask you guys a question? Really?
Sure.
So, like I said, I've been doing so much research, and so I'm hearing about high levels of vitamin C could potentially be some type of cure for breast cancer.
Well, the data behind that is vitamin C is an important component in cell regeneration and strength of the fibroblasts.
Mm-hmm.
Now, whether it's preventative, that people are looking more of it being preventative,
okay,
than as a treatment source.
Okay, because they were saying that if you have breast cancer, you should push your doctor to give you high dosages of vitamin C through an IV. Like I said, I came in the health field, so I don't believe. Yeah.
Most multivitamin liquid that they have, I don't know if there's one specifically for vitamin C. There are multivitamins that they put in, TPN, total parenteral nutrition and things like that. As to the exact concentration of vitamin C, I do not know.
Okay.
And also, vitamin C is well absorbed in the GI tract.
Yeah,
You
take the
don't have any
tablets.
GI issues. More than likely, you can obtain that high dose by taking it orally as well.
Okay. Okay.
So Monique, I want you to tell us a little bit. Yeah, I'm going to let you do a shameless plug. Tell us what's happening this weekend with Monique Denise.
So of course, breast cancer is my life. So like I said, and being in the health field, I just still have that passion to educate. So I've made a vow that every year I do a breast cancer event. So this Saturday, I've partnered with the local breast cancer foundation, Giles Jules, and we are hosting a Peak Out casino night, which is also my album release party. But what we're doing is we're honoring local African American survivors and warriors. We're letting them tell their story. We're educating people about the same information that you guys are talking about. And then we're just celebrating life. So we have Paris Winningham, who was on NBC The Voice. He came in third place. He's going to be performing. We have the DJ from the Apollo in New York City, and he also opens up for the Kings of Comedy tour. He's the DJ. He's coming in. And then I will be performing some songs from my new album, and we're just going to have a good time. We have casino tables. We're going to have a good time.
Do
You
you
know,
still
also,
have tickets
African
available?
American women,
You
they
say
run
what?
their Sisters Network, which
Yes.
is an organization of African American
Right.
women with breast cancer who've been
Mhm.
in Jacksonville supporting other ladies with breast
Mhm.
cancer. And you know why it's important to listen to another sister? Because when we get chemotherapy, things happen to our skin that doesn't happen to other folks. You
And
know,
my
their
feet
nails, their hands,
right
feet,
here.
you know, the hair.
Yeah.
That granted, everybody lose their hair, but if you look at a sister's hands that's
Yeah.
getting chemotherapy and her nails, that's something that they can only relate to each other about because the other people don't get that.
Yeah.
So chemotherapy has a different way of affecting the outward presentation of the African American woman or
And we
within
take
the
pride in
African
how we look
diaspora.
too.
Right,
It's
right. Take
hard.
pride in how we look.
That's
It's
right.
hard.
Absolutely. So Monique, how has, Dr. Jones mentioned the Sisters Network. What resources have you found to be useful or helpful to you as you have been over the past 5 years? And that facial expression looks like not really, huh? Not much. You don't have to name organizations, but have you had much help with any resources
So
to
I
assist
have.
you?
I think I've touched bases with and connected with many of the African American foundations locally. Um, but I know when I first started this journey, the organizations that they partnered me with, if I was not in a strong place, I really would have went into depression and had some type of emotional breakdown because every time I went, I really would have cried because when they gave me this stuff, it wasn't for me. When they gave me the wigs weren't for me. I mean, I literally looked like Marilyn Monroe. Like that's the kind of stuff they gave me. And I had fun with it. I made fun of it because I was in good spirits, but I could see how somebody who wasn't in good spirits it would be hard. And then a lot of the programs that we don't have as much funding to do as much as we want to do and to cover the number of women that we have. So it's kind of hard, but I mean, there are some amazing services and programs and resources out there specifically for the African American women. Like one of the groups that we're working with, they are donating a free wig to a breast donor. I mean, a breast cancer fighter, because they understand that we take pride in that thing.
So
So
what would you say that, in terms of resources that would be needed, and if someone is or other than that, the other part of the question that I have is if someone just got a breast cancer diagnosis today, what would you say to them? Like, okay, this is what you need to do first, other than talking to your doctors, obviously. Is there any advice that you could share with them or?
Well, I mean, definitely they need to connect with, if they're African American, they need to connect with the Sisters Network. Definitely. They need to connect with some people that look like them, can help them, um, and talk their lingo, because a lot of us get depressed. We join the support groups at the hospitals and we still don't have people that look like us. So join a support group, or find a foundation that is for Black people. Get connected. um what was the other part of your question? I'm sorry.
Just that you, what type of resources do you think that are needed? Like when you got your diagnosis, it's like I need, and you talked about the wig. Is there anything? And you talked about the inadequate funding for foundations that support African American women. Anything else that you want to mention?
So you definitely need the wigs. You need the skincare, because our skin breaks down totally different. It's affected differently. You need the resources as far as helping these families, because most of the time these are single mothers who are out here being diagnosed with breast cancer, but they have like 5 kids at home. So they need support. They need friends. They need people who can come clean. That's the thing. Like, you can't get up and move around. They need people to come cook. They need, I mean, you name it, they need it. I mean, the things we take for granted on a daily basis when we're in perfect health, we need it. But the biggest thing is, a lot of us are too prideful to ask. And one of the biggest things that I encounter is, because I smile and I'm upbeat and I'm joyful, people think, oh, she got it, she's good. But really, I'm struggling over here, to be honest, if I'm just being brutally honest. But I put on a good face, because walking around with a sad face does nothing. It doesn't help.
So you basically saying we for sure need culturally sensitive organizations,
We do.
that more of them and more that get more involved in the community, greater funding for those organizations
Exactly.
to participate in the care of the community and people in the community.
Exactly.
And so, yeah, I get it.
And you know what's interesting? When I discuss with some of my patients, I would say, you just started it. What's the hardest thing? You know what the sisters say? I just wish for the first week someone would just bring food to my family, already cooked, that we can just eat. Because I don't have it in me to get up and go to the stove and cook food. And I don't have the resources to every night get a decent meal for my family. You could always get something that's fried that has grease in it, but I'm talking about a better meal.
Yeah.
Real food.
That is what I have found people ask me about. Even if, and that's something, we have organizations in town, and but somebody's gonna have to agree. Well, hey, Monday night the two of us will cook. Whatever. Tuesday night you do it. Wednesday night, even that first week of chemotherapy, when everybody's, it's a beating. I mean, it's not. I've been doing this and I've seen how people react. It's not easy.
And the biggest thing too is, people, you get the phone calls, you get the text messages, and people say, whatever you need, let me know. And then when you tell them per se, they don't necessarily come
They
through.
they go silent, crickets, right?
They don't want to know.
Yeah.
Right.
Yeah.
That to me is one of the things I've heard.
Yeah.
Where
you really just need to pop up. Just come. You know what we need. Just do it.
Just drop a meal. I've got myself and 3 children. Just bring me some food that I can eat. That I don't have to get up and try and cook.
Just come by and say, hey, I came by. I'm going to clean the house for you. I'm going to do some laundry. I'm going to do something. Right. Just come do it. Yep.
Right.
Well, this has been a very interesting discussion. Monique, thank you for your open and honest, sharing your journey. And Dr. Jones, thank you as well. At the end of every show, it is the end of the show. And of course, you both are always welcome to come back. But at the end of the show, we'd like to give our guests an opportunity to share their final thoughts. So, Dr. Jones, what are your final thoughts on tonight's topic?
My final thoughts are early diagnosis, early screening, and become the expert at what your breast feels and looks like. The person, don't rely on your doctor to say, well, your breast looks different. No. You need to be the person who looks in the mirror, notices how your breasts hang, palpate your breast, make sure you know how it feels, because when you feel the difference, get right on it. Don't ignore changes in your breast.
Yeah.
I've seen people that show up with a cancer the size of a melon. And I asked, what do you think was going on here? Well, if they biopsy it, air will get on it and it'll grow real fast. No, that does not happen. So become the expert at understanding what your breast looks like and feels like. And please do not miss your breast cancer screening exams annually. And ask for 3D, get a tomosynthesis. The 2D they should just put those away somewhere.
Tomosynthesis being TOMSYNTHESIS.
That's wise. Yeah. Tomosynthesis.
Thank you, Dr. Jones. Monique, what are your final thoughts regarding tonight's topic?
I mean, I enjoy it. It's a great way to start off Breast Cancer Month. But as we've been informed, just everybody go get checked. Don't be too prideful to ask for help. Don't be too prideful to talk to people about it. And just, if you do have it, just embrace it. Find you a support circle. There are so many women like myself around the area who have it, and we're here to support, and we want to support. So just don't be afraid. Just, be positive.
So how do we support the Monique Denise album release? How do people get your album, Monique?
Well, once it will be released, I will be promoting it. But the event itself is on Eventbrite. It's called Pink Out Casino Night. Here I am, Pink Out Casino Night. But you can also find my Facebook page, my Instagram, all of that. MoniqueDenise.com as well. And click the link to purchase a ticket. We only have a few more tickets. We're almost sold out, which is absolutely amazing.
That's wonderful. And I have my ticket, so
we're going to have a good time.
Thank you, Monique. Dr. Kane, what are your final thoughts for tonight's topic or show?
Just to top a couple of quickly top a couple of loose ends. As Ken, I'm gonna piggyback on what Ken said, and that is you know your breast. You should know your breast better than anybody else. And one of the lines that I use with ladies is that as a physician, we only get one shot a year at your breast, but you can have 365 shots a year to examine your breast on a daily basis or monthly basis, whatever it is. But you have a lot more opportunity to examine your own breast than do Ken or myself in terms of an annual exam. Yeah. So stay in touch with you and examine, your breast on a regular basis. The other thing is, making sure that any physicians that you tend to talk to, if you don't get the right vibe from them or think that you're not sure if they're the person for you, don't be afraid to get a second opinion. It is your life. And, that physician, whether it's me or anybody else, will go on with theirs. And, but your situation will not turn for the better unless you make it happen, help make it happen, if nothing else. Mm-hmm. And then the last thing is I would like to make sure that people get the address and whatever it is that they need, the information. And I went out for a second. I wasn't sure if you gave it, but give the information to be able to get to that event. So I don't know the specifics about the event, where it's at, or anything along that line. So,
okay. It's a link. I can send the link that can be posted with the video, or I can respond to the live stream on the Facebook page with the link.
Got it.
Yeah, you can just put it in the chat, Monique, and we'll get, or text it to me and we'll make sure that it's on our website. Well, thank you, Monique. Thank you, Dr. Jones. And of course, Dr. Kane. Very, very interesting show. And Monique, we're praying for you, as Dr. Jones said, and as your son, since I know him, Christian says, You got this, Mom. You
I
got this.
got it.
Monique walked into my office, just to tell a real quick story as we wrap up. Monique walked into my office years ago, bubbly personality. I think she was still a student at UNF at the time and needed to come volunteer with me. And she did. She wouldn't go away, y'all. She was just like a little ant. She just wouldn't go away. And then she showed up again years later. So when she got that cancer diagnosis, we were working together. At this time, she had graduated and actually became an employee at the health department. And we were there for her then. And I have admired her tenacity and her just desire to sing and really enjoy her life. So thank you, Monique, again. Thank you, Dr. Jones. And for those of you, if you did not get the message, the main point that I think we all learned tonight is the importance of getting regular screenings for for not just cancer screenings, but all screenings. Make sure you adhere to the recommendations that have been presented for you. If you don't know what the recommended health screenings are for you, we're all used to Googling things. Google recommended health screenings for however old you are, and you'll find that typically on the Centers for Disease Control website, Department of Health and Human Services, in other words, I'm dropping reliable sources where you can get information. Also, make sure you get a good physician like Dr. Rogers Kane and Dr. Jones, for example, who go outside of their offices to educate people. Thank you, as always, for listening to our show, and join us next week on Pause for the Truth. And if you have not gotten all of your COVID vaccines and boosters, there's good news. If you've gotten one vaccine, the latest vaccine or booster, the Omicron bivalent vaccine, once you get it, hopefully, Dr. Kane, I'm not a doctor, but I'm hoping this is it. But we all want to get back to some sense of normalcy, although some people are. But I had a friend to tell me they had a friend that actually died from COVID recently. So people are still dying of COVID. Get your vaccine. Good night, everyone.
Good night.
Okay, good night.
Good night.
Good night.
Thank you, Monique.